Thanks everyone for joining today. We are excited to be hosting this webinar. It's part of a series, Mental Health in a Time of COVID-19, Preparing Leaders to Address the Challenge. I'll turn the presentation over to Shannon Royce. Shannon?
Well, hello, my name is Shannon Royce, and it's my privilege to be the director of the Center for Faith and Opportunity Initiatives at the Department of Health and Human Services. That's kind of a mouthful, so we tend to go by the Partnership Center. We are so happy that you are here with us today, that you've decided to take an hour out of your day to share with us as we have this conversation about mental health in a time of COVID. The webinar is the first webinar in a series of 3 and perhaps 4, we're talking about a 4th at this point, to address the challenges that we're seeing following the COVID-19 pandemic for those who are experiencing that. We want to understand better the challenges before us, those who are struggling at this moment, and then the challenges that we anticipate will follow. And we have 3 magnificent speakers to share with us today, and I will introduce them in just one moment. But before I do, I want to mention a few housekeeping items just so that we're all on the same page. The first is this is an educational webinar. It is not intended for press purposes. So if you are a member of the press, we would ask that you disconnect, and we would be happy to connect you after the program with our press office for questions or comments that you might have. If you're having difficulty hearing us today, you might consider using the phone number that's there on your screen, the Zoom phone number that's offered. We find that sometimes people have a better time hearing through that means. Sometimes it's a problem with your internet connection or what device you're using, and so that might be helpful to you if you're having trouble hearing. We also will be sending a link to the webinar. We are taping it today, and so we'll be sending a link to the webinar in the follow-up information that we send to you. And so questions or comments after the webinar, please feel free to reach out to us at our website at partnerships@hhs.gov, partnerships with an S at hhs.gov. Finally, we do have a very full program today, and we want to have you do your questions in the Q&A feature. So if there are questions that you have, please click on the bottom and go into Q&A and put your questions there. And just to test that out, if you will, tell us where you are watching from today, the city and state where you're watching from today. We would love to be able to see that and get feedback from you. Let's take a moment. Wow, I see Hampton, Virginia, Monroe, Wisconsin, Fort Worth, Texas, Orlando, Florida. That's terrific. Thank you so much for sharing that with us. And you can continue to share that because we want those who are with us today to hear your comments and your questions as they continue the work that they're doing. So here at the Partnership Center and at HHS in general, we're working day and night right now to address the COVID-19 pandemic and the implications of that. One of the main areas in our office we've been working is the mental health challenges that people are experiencing as a result of the pandemic. For many people, even those people who have no mental health diagnosis, they find that they're experiencing increased fears and concerns. And in some cases, those fears and concerns are so extreme that they really do need to seek professional assistance. And that's why we decided to do this webinar today, to help faith and community leaders understand what they need to know to be prepared, not only for the questions that are arising today, but for what we anticipate will be a second wave of mental health concern that follows the pandemic. Today, we want to spend some time understanding the mental health impact of the COVID-19 pandemic on so many people. We want to consider how the outbreak of COVID-19 has placed overwhelming stress on people and communities, and consider the impact of that stress on those folks' mental health. I heard just this morning of an ER doc from New York City who was so overwhelmed with the challenges that she regrettably took her own life. And we are hearing of increased concerns, both from mental health concerns and some who unfortunately are taking their own life as a result of just the overwhelming stress they're experiencing. So we just want to step into that with the three speakers we have with us today. We first have Dr. Steve Gersovich. Dr. Gersovich is the founder and president of Key Ministry. Key Ministry develops collaborations with church leaders around disability and mental health. Dr. Gersovich is a child and adolescent psychiatrist who combines nearly 30 years of knowledge gained through clinical practice and teaching with extensive research experience. Our second guest is Dr. Tim Murphy. In addition to being a former congressman, Dr. Murphy is a licensed clinical psychologist specializing in resilience and recovery from psychological trauma. He's a national leader on mental health issues and the author of multiple books and resources on mental health. And our final guest today is Kay Warren. Kay co-founded Saddleback Church with her husband, Rick Warren. And after the death of their son, Matthew, who had lived with serious mental illness for most of his life, she founded Saddleback's Hope for Mental Health initiative as a way to support individuals and family members with mental illness and suicidal ideation. Again, we're so happy to have you join us today, and we look forward to hearing from our speakers. Dr. Gersovich, turn it over to you now.
Well, Shannon, thank you so much for inviting me. And I have to say that it's a great honor to have an opportunity to present alongside two of America's foremost mental health advocates. And one of the challenges that I experience on an ongoing basis as a child psychiatrist is that when I'm involved with treating kids, we're oftentimes risk involved treating. There's a risk involved with not treating. And all too often, we're in a situation decisions in the face of insufficient evidence. Next slide, Ben. And so one of the things that a lot of faith leaders are going to be wrestling with in the coming weeks and months is there's an upside to reopening your congregation, your place of worship. There are potential downsides, and people are struggling right now to kind of figure out what the right thing is to do. So here in Ohio, where I think we've been recognized for having a very effective, response to the coronavirus, Amy Acton, who is our director of public health in the state, comes on every day at 2:00 in the afternoon and did a wonderful job talking about why it was that we needed to do social distancing, to take some of the other precautions that were necessary to be able to flatten the curve. But as Shannon touched on, almost intuitively, being in the mental health field, we know that there's going to be another set of challenges coming. And so most of the folks who would be watching the webinar today, I think, are well aware of why we've taken some of the public health measures that we've taken. What I want to talk about is this downside that folks are increasingly talking about, which is the longer that this goes on, there are going to be other complications, particularly from a mental health standpoint. And while, there's clear evidence that the actions that our state governments have taken, have saved lives, the concern is, well, what's the price potentially going to be on the other side in terms of increased rates of suicide and an increased prevalence of other mental health issues. So if you can go next slide, Ben. So one of the things in thinking about this is that, again, as a good psychiatrist who helps teach, evidence-based medicine at my med school, I wanted to go into the data and see, well, what kind of research that we have that would help to guide us in terms of predicting what we might experience in the mental health field. And one of the challenges is that there really aren't a lot of situations to which we can compare the situation that we find ourselves in right now. You know, think about like different issues or different parts of our current circumstances that could contribute to a significant wave of mental health concerns would be the extent of quarantine and social isolation that we're all going through. A key issue going forward that Shannon touched on in her introduction is the extent to which the doctors, nurses, you know, and our first responders who are working in emergency rooms and intensive care units are being traumatized by the experiences that they're having caring for people with COVID-19. There's the whole piece about the impact of unemployment and the relationship between unemployment and an increased suicide risk, and also substance abuse issues. Our kids have been out of school here in Ohio now. This is going on week 7. And what kind of impact is that potentially going to have in terms of their mental health? And one other issues that I haven't heard a lot of people talk about is that, you know, at the same time that we have this, we anticipate this growing need for services, because of the way that our mental health system's designed, the capacity to be able to provide those services may in some instances be more limited than what we currently experience, which is already a problem. And an example of this in my line of work is that in some communities around here, the majority of mental health care that kids get is through their schools. When you close down the schools, where are they able to access care? Or if there's a telemedicine response, you know, what if you're a lower income family in the middle of the city that doesn't have the kind of high speed internet that allows you to get good quality mental health care online? You know, so all of these are considerations that we have to take a look at. But these are some of the things that guided me in looking at the literature. So if you can go to the next slide. You know, we'll start off by looking at the whole piece around quarantine and social isolation. And there are a couple of studies that you're going to see. You know, the first of which was done in the aftermath of the SARS epidemic, looking at people who had been quarantined in Toronto. And so around 2/3 of the folks in this particular sample happened to be healthcare workers. And it's important to note here that the average length of quarantine was 10 days. You know, that we have a lot of folks who are spending considerably more time than that by themselves because of quarantine or social distancing. And around 30% of the folks, when they went back and interviewed them roughly 5 weeks after they'd been quarantined, met criteria for post-traumatic stress disorder. And again, roughly 30% at that point met criteria for actively being clinically depressed. The second study was a broader study looking at the issue of quarantine. Some of this included data that had been obtained from Africa, other places outside of Toronto. And again, similar length of quarantine on average, 10 to 14 days. And they found that after that experience, 30% of the kids and 25% of the adults met criteria for post-traumatic stress. And the PTSD scores of the kids who had been quarantined were 4 times greater than those of their peers. You know, so again, depression, PTSD are going to be obvious concerns. Next slide. Now, one of the questions we get into then is the impact specifically upon healthcare providers. And so there's a study from China in the aftermath of SARS, and we had discussed a moment ago that there's clearly this increased risk of depression after the experience of being quarantined. Well, it turns out that this increased risk may be present for a very long time. So in the study by Liu, after the SARS epidemic, the clinicians who had been quarantined compared to their peers who weren't were almost 5 times more likely to be experiencing symptoms of major depression 3 years after the fact. So when we start thinking about what we're going to need to do to support folks from a mental health standpoint, there are the immediate needs that Shannon was talking about in her introduction. But this wave is not something that's likely to go away over time, and it's going to be something that we're likely to be dealing with for a long time. Now, there was a more recent study looking specifically in China, in Wuhan province, at mental health issues among the medical staff who had been caring for COVID-19 patients there. And in the aftermath, they found that half of the docs were depressed, nearly 45% met criteria for an anxiety disorder, and almost 3/4 of them had some signs or symptoms of post-traumatic stress. And the group that I think is going to be most significantly affected by this is our healthcare workers, and thinking about how we're going to go ahead and support them, through the work that they need to continue to do, and support folks after the fact so that we don't have any more tragedies like what happened to the emergency room doc in New York in the last couple of days is going to be critically important. Next. Next slide, Ben. Now, another issue, and this is something, again, like you're online, you hear, debated in different public forums, is the impact of some of the challenges that we're experiencing right now in the economy and how that relates to mental health issues. There's a study that was done, and on the screen in front of you, and this was written up about 5 years ago in the British Psychiatry Journal, where they looked at the relationship between economic effects during the Great Recession of 2007, 2008, and the relationship between those economic impacts and suicide in 64 different countries. And so one of the things that they found was that the experience of becoming unemployed increased your risk of suicide somewhere between 20 to 30%, with the 30% number being more characteristic of people who had been in countries where there was a very low level of unemployment prior to the economic disruption. And you think about the fact that 2 months ago that we had the lowest unemployment rate in America that we've had in the last 50 years, based upon, again, this research from 4 different continents, 60 different countries, with 22 million people having lost their jobs in the last month. This is something that we need to pay very close attention to among this population. Next slide. Now, here's another study that was published, this is about 2.5 years ago, where they were looking at the relationship between unemployment and overdose deaths. And so what they had found was that for every 1% increase in the unemployment rate, the suicide rate goes up by or not the suicide rate, the rate of death from opioid overdoses goes up by 3.6%. And the rate at which people are brought to emergency room departments goes up by 7% for every 1% increase in unemployment. So, if you take a look at the current statistics, and if we go from 4% unemployment to 20% unemployment, that works out based upon the data to about a 59% increase in accidental overdose from opioids, so that we're going from 47,000 overdose deaths potentially to as many as 75,000 overdose deaths per year. And while I think it's been burned into everyone's mind, sort of the image of the refrigerator trucks outside of the hospital in New York, it was only a couple of years ago that there were refrigerator trucks outside of the hospitals, in my part of the world, in Akron and in Canton and in Cleveland, because of the victims of the opioid epidemic. And so, we have to be very conscious that while, again, we're doing lots of steps, to save lives, the more socially isolated people become, the more likely they are to abuse substances, and that we may end up paying a price for this over the next year by looking at death rates by opioids as opposed to death rates from COVID-19. Next slide. And so I want to take a little look at what do we know and what kind of research do we have about what folks have been experiencing during this outbreak. And the data you have in front of you is from a slide. This is a survey of 3,500 adult Americans, demographically representative, that was done during the first week of shelter in place by McKinsey and Company. And so subjectively, and this, we're not talking about having a clinical diagnosis here, but subjectively, they found that roughly 60% of the folks who responded to their survey, were experiencing feelings of both were experiencing feelings of anxiety and or depression. That's 75% for folks who had either had a cutback in their work hours or had lost their jobs as a result of some of the steps taken in the economy. And when you take a look at the measure of distress that folks were reporting, 80% of all adults were reporting at least moderate to high distress. That was closer to 90% for people who had lost their jobs or had had some reduction in their work hours. And I think that the level of substance use issues that they had found ought to be of concern to all of us, where 1 out of 4 adults had reported binge drinking in the last week. 1 out of 5 had taken prescription drugs for non-medical reasons or to self-medicate. And 1 out of 7 adults in the first week of the quarantine reported using illicit drugs. So next, there's a study that looks specifically at 2,000 teens and young adults. This was done in the UK about a week into their social distancing. And what they had found was that, with teens and young adults who had already had existing mental health conditions, that almost 1 in 3 described themselves as getting much worse. Another 50% is a bit worse. And, similar to the concern that I raised at the beginning, almost a quarter of them, because of different facilities being closed, issues with telemedicine, issues with access, clinicians maybe needing to leave their jobs because they themselves were sick or were caring for other family members. Nearly a quarter of them weren't able to access the established mental health support that they already had in place. Next slide. And so this is a summary. This was a paper that was published in The Lancet about 2 months ago, reviewing, again, relative research looking around quarantine, social isolation. And essentially, if you were going to try to design a study that would precipitate post-traumatic stress, anxiety, depression, other emotional behavioral issues, substance use, we're all in the middle of that kind of a study right now. And again, that when you take a look at, what people are experiencing, and you take a look at the levels of stress that are being reported, it seems inevitable that we're going to have a very significant increase in mental health needs. Next slide. So there was a paper that came out, this is a couple of weeks ago, in the Internal Medicine Journal of the American Medical Association. And now those of us who've been in the system, I think Dr. Murphy's going to be talking about this at more length, are well aware of some of the deficits in terms of service capacity. And so when you think about the number of people who are being impacted, we're going to have to think about ways of caring and supporting these folks that exist outside of the mental health system. And so again, when the folks at American Medical Association are talking about training non-traditional groups to provide psychological first aid, in my mind, the first folks who come to mind are different faith leaders and places of worship, because these are already natural systems of support that many, many Americans turn to in a time of need. Next slide. And so in the work that our organization has done, supporting churches and other faith-based organizations in terms of responding to COVID-19, 2 things in particular that we have been advocating for on the basis of evidence showing that it makes a significant difference are, first, psychological first aid training. There are 2 randomized studies that I'm aware of that have shown that psychological first aid brings about significant reductions in anxiety among individuals who are presenting in a time of crisis or after a natural disaster. One of the other steps that we've been encouraging churches to take as they and other religious organizations as they seek to respond to the need is that, you know, as they're considering ways that their people can serve and people can help out, we've emphasized the importance of places of worship giving families the opportunity to serve together. Because there's data looking at the ability or what kinds of steps can be taken to attenuate the possibility of adverse childhood experiences among kids who were involved in natural disaster. And the traumatic experience was less impactful to kids who were involved with their families in the preparation process and involved with their families in responding to the process. So that by giving kids the opportunity to serve alongside their parents and alongside other trusted adults, you help to promote a sense of agency that seems to protect against the trauma that's associated with the immediate experience. So at this point, I'd like to close and have Shannon go ahead and turn it over to Dr. Murphy.
Thank you so much. Steve, that was really insightful. The depth of the research you've done is so significant, and we're grateful for that. And now we turn to Dr. Murphy. I know, Dr. Murphy, you and I have had several conversations lately about the concerns you are seeing and hearing, and just want to open it up for you to share from your insight and your experience. Thank you for your time today.
Thank you much. Thank you so much, Shannon. And it's an honor to be on the same platform as Dr. Steve, and also with Kay and with you. This is an incredibly important issue. We get our daily updates of what's going on in the nation with the spread of this disease, but we have to remember that there's a very, very high risk group out there, not just for the coronavirus, but actually for the disease of mental illness. I want to talk about two aspects of this, if I may, that are of a big concern for us, that we can then look at what can be done about this for the future too. So let me review this in a couple ways of how bad this problem is in America. But I'm going to try and end on a note of optimism, so let's not worry yet. First of all, a lot of times people refer to behavioral health, and behavioral health can be a wide range of things, from just having difficulty through the day. It's the child that's not behaving themselves or acting up wrong. It could be attention disorders. It could be anxiety about the world. It could even be stress reactions or difficult situations, ranging from I'm having a tough day or I've had a tough life to post-traumatic stress and post-traumatic stress disorder, which sometimes can be pretty severe. I mean, I've dealt with a lot of military and during my years in the Navy and in my current practice. It can be pretty debilitating. There's also a level of serious mental illness. This is schizophrenia, bipolar, schizoaffective disorders. It's not going to be a quiz on those things, but I want you to understand something very, very important, and how this group is at highest risk, and how there's no one to care for many of them. So the number of people with serious mental illness, about 10 to 14 million in America or so. It represents about 1.5%, maybe 2% of the population with these problems. Now, schizophrenia, if you're not familiar with it, those are the things where a person's just not in contact with the world. They may have delusions. They may have hallucinations and things they see or hear or smell. They may have negative symptoms of being tired, exhausted, disturbances of their whole thought processes that's going out there. And this is a brain disease. This is not from bad living. This is not from mistakes they made. This is a brain disease. And some of the aspects of this is that people themselves oftentimes are not even aware that they have it. That's a condition called anosognosia. Now, it can be treated in some ways with medication. The earlier, the better. But here's our problem in America. We don't have enough people to treat them. So what happens? In fact, if you look at maps of the American Academy of Child and Adolescent Psychiatry, they'll have a map for every state out there, and you'll see that most counties in America have a gray color. That means there are no providers. Half the counties in America have nobody to treat. And of the many psychiatrists and psychologists out there, quite frankly, a lot of my colleagues don't even treat severe mental illness. So where do they go? Well, about 40% of them don't get care at all. Many times they don't want to take medication. And we used to have a lot of psych hospitals in the 1950s, over 500,000 hospital beds back then, and now less than 38,000. Well, what happened to them? Well, they're in jail. They're homeless. They're ignored. They are the least lost and lonely. They're the ones that oftentimes don't care about. In fact, it's estimated 16 to 25%, or maybe even 50% of people in our prisons and our jails have a pretty significant level of mental illness. And what we see with that is now our jails are actually emptying out a lot of folks who are not violent, sending them out. Some of the people with severe mental illness, and they don't get treatment there. Well, this problem compounds as it goes on. And many of them, they're in the community right now, they're at home, maybe they're on their own, and not really understanding or comprehending what's going on. Those have been dismissed from prisons. They may have enough medication that they've taken, and in about 3 or 4 weeks wears off. So we are now at that time when we see increased problems. Well, beyond that level too, we've criminalized mental illness, and that's the biggest stigma, because people who are mentally ill, they don't want to be associated with going to jail or something like that. That's one part of the problem. Here's another part that's emerged. We don't have enough people to treat, and that is issues of domestic violence, abuse, and neglect. Many cities around the country that keep track of data are reporting they have increases in those. They are, in some counties like where I am in the Pittsburgh region, is saying, well, we haven't really seen an increase, but here's where that data is totally wrong. The people who are mandated reporters, teachers, clergy, pediatricians, emergency rooms, look at the list there. They're not seeing children anymore. They're not seeing the adults anymore. So any town that sees a decline or leveling off, I think it has totally false data. This is where church leaders can be absolutely essential in making sure they're continuing to connect with these families to see how they are, to check up on them, because they're not being seen. Those who have the phone systems, the drive-by, the stop by and say, hey, I'm gonna give you a call and talk to you from your yard, just to have that little glimpse of any family you see is at risk is so important. The other aspects is too is that Steve had mentioned, the increase in suicide, the increase in substance abuse. I know many states are seeing increase in overdose deaths. Many people are reluctant to go to hospitals for care, call the emergency rooms or something. And so we have problems emerging from there too. It paints a grim picture overall, that the seriously mentally ill, even on the best of days, we do not have enough people to care for them. We do have a situation now where many providers like myself, we're seeing all our appointments by telemental health, and many insurance companies have waived the fees for copay. So it should be easier, but there's still a disconnect for many folks in getting out there and getting services. So what do we do? Well, this is where a faith community, and those of you who are out there, I thank you so much for doing, because you not are on the front line now, not just on the front line now, but you have been there for centuries. That you are the ones who first identify when people first come to for their concerns. And I don't expect you to be, and none of us expect you to be licensed therapists or skilled at this, but sometimes the power of listening and the power of asking someone to tell their story and finding supports and referring them is such a great force multiplier. And in the faith world, it is one where the stories that can be told, even to those who are marginally believers, but the faith stories are so important part of healing. In the field of psychotherapy, what is the standard of counseling is cognitive behavioral therapy. We work with people to understand their thoughts, how their thoughts lead to emotional issues, behavioral issues. And so we work to change the way they think. And in the faith world, the way I look upon this is you can actually see not just research that's been done in the United States in the 90s and 80s or so on what cognitive behavioral therapy is, but Romans 12:2, that you can be transformed from a renewing of your mind. Or look back in the Old Testament or the Christian Old Testament or the Bibles, others, that Ecclesiastes and Solomon talking about the way you have to think about the world. You know, some things are just going to continue on. I look at also that how we deal with trauma. Faith traditions and faith stories are so incredibly important, because I can't think of many people who are cited in biblical references in any faith that haven't faced tremendous trauma but have overcome it. We have become a society that somehow looks upon trauma as, once we face it, is inevitable. Well, you know what? About 70% of the population at some time in their lifetime will face what is defined as a traumatic event, something that may be life-threatening to them or life-threatening to someone else. And that's different from just a stressful event. But what happens is, is nowadays we almost automatically think, well, that's going to lead to post-traumatic stress disorder. Not necessarily, because what happens is, as faith leaders and as therapists, by helping people understand, oftentimes talking through their story, we can get people to the point where they can have some power and control. The being overwhelmed by it is not inevitable. In fact, I will tell my patients that you don't have to be a victim. You can choose to be the victim that always has that boulder on top of you crushing you. Or you can also work to be a survivor. You know what? I'm moving on with my life. I'm going to get beyond this. I'm going to get on with things. Or you can be a thriver. And that is turn it into a source of strength. And in the religious world and in the faith world, it is one where there's constantly are stories out there of how people have taken that, and that has been a powerful force multiplier of getting people to understand you can, you must, and you will overcome this. So as people are looking at the constant strains of finances, and that is something that adds to the continued trauma and stress. As they're looking at rebuilding or recurring psychological scars from their past, as they have the current stresses, sometimes the stress is being too close together, and sometimes it's not being able to go to other people. The connection you can help with people with is powerful. And that's what any of us would actually be doing too, as therapists, to help people understand that. I know many times we also have to look at not becoming victims ourselves, that there can be compassion fatigue. And I know there are sources out there for clergy to make sure they're taking care of themselves as well. And I encourage you to do that. Don't get caught up in a situation where you're taking on too many burdens yourself. None of us have to be heroes. It's important to advise people, and many of you have great networks too, that there is a great value in doing volunteer work, to send people information on message of resilience in movies and books, keeping their minds sharp. But one thing I wanted to mention too that's a powerful psychological tool for people, and that is keep a journal. Write down what is happening to you now as a way of reflecting on it, but also it's a source to go to in the future. Not just months from now, but actually years from now. We look back on the greatest generation, our grandparents, great-grandparents from World War II, and the letters they wrote from the battlefield were so incredibly precious as we look back on how did people survive. Well, you know what? We're writing those battlefield letters now, and they're a great value. And all of those who are clergy out there, I hope that's something you're encouraging your flocks and your congregations to do too. It helps you document these things, it helps you see things, and as they share them with you, you may also find hints there of some overwhelming psychological stress, and then you'll know, who do I refer on to a therapist? Who do I counsel? Who do I pray with? Who do I assist in some other ways? We have a lot to go through and a lot to get together on this, but understand the whole world of professional psychologists, psychiatrists will not be enough to handle that. But together, you can be part of the triage system, offer the comfort where you can, refer on where you cannot, but never let yourself be overwhelmed by this all too. We have a lot to go through, and we'll continue to work on this together. And so I turn it back to you now, Shannon, and continue on with this. We'll take some questions later. I should say, I have a LinkedIn, Tim Murphy, PhD, if there's other people who want to connect with me, and I also post there about continuing message on this too. So.
Wonderful. And we'll make sure to put that in our follow-up email that goes out, Dr. Murphy, to share that contact information for all of you. That was really insightful. I appreciate the concern, particularly for those who might be in abusive situations. I think that really is something that should concern all of us. Kay, I'm so looking forward to hearing you. You have been such a leader in mental health for those living with mental health challenges, as well as their families. And so I appreciate your being with us today and look forward to what you have to share with us.
Thank you so much. This is certainly a time of unprecedented stress and disruption. I don't think any of us have ever experienced anything quite like it in our lifetimes. And because of that, many people are floundering, completely overwhelmed by the collective and individual uncertainty, the inability to see beyond this moment, and unclear as to what our new normal life is going to look like. And to be honest with you, I don't like it. I mean, to state the obvious, I wish things were different. Honestly, I want my old life back, even though my old life had some challenges and some problems. But You know what? My old life didn't include isolation from my grandkids. My old life didn't include deprivation and restrictions and limitations in every aspect of my life. It didn't include the imminent threat of disease and death. And honestly, as I kind of take a look over my shoulder to the last 2 months, my life before looked pretty good. And I was thinking yesterday as I was getting ready for this of one of my favorite lines in J.R.R. Tolkien's Lord of the Rings, in the first book, Fellowship of the Rings, where Frodo, the Hobbit, has been given this heavy responsibility to take back this very dangerous ring and destroy it. And he's overwhelmed by the burden of what has been placed upon him. And Gandalf, the wizard, and here in a conversation, and Frodo says to Gandalf, I wish it had not happened in my time. And Gandalf says, so do I. And so do all who live to see such times. But that is not for them to decide. All we have to decide is what to do with the time that is given us. And the truth is, nobody else in history has had our particular moment. God could have had us live in the past. He could have had us live in the future, but he hasn't. He has us alive right now. And this is our moment. I mean, there was the World War II generation and the Vietnam generation and the Civil Rights generation. And apparently we're the COVID-19 generation, which means that we have been given a very heavy responsibility. We in the faith community, we as a country, as a world, as a global fellowship of people have been given a responsibility, and we didn't choose this time. We didn't choose the circumstances of this time, but the question is, what are we going to do with this time that has been given to us? How will we steward, we in the faith community, how will we steward and shepherd this time in history that we've been given? Well, I can tell you what I know for sure that we cannot do is we cannot go to sleep. We can't tune it out. We can't let fear dominate. We can't let inertia overtake us. We can't wait for somebody else to show up. We can't abandon hope. We can't ignore the needs of millions of people who need the assistance and help that we in the faith community can offer. It is definitely time for us to step up. I know that much. So I want to just go over about 10 or 11, 12 things that I think are practical that almost any church, any congregation can do together. I have a website, kwarren.com. If you go kwarren.com/mental health, there's a lot of resources for the average person, for the average clergy member. And so if you see some things that will go fast through these slides, that you want more information, or you want to know how you can actually get involved in it, please email us and our team will help you. The very first thing is I really want to encourage you to collaborate and cooperate with other churches or other faith communities in your area. You need to, if you're a smaller church, join in with the efforts of larger churches or band together with smaller churches in your area to maximize the impact in the community. You may be a small church and you are not really sure some of these things that I'm saying that you can do, but when you band together with others in the local faith community, you can make a much larger impact. Next thing, next slide, is I'm going to give you some practical things that you can do now. Now, this first one may seem so obvious, it's a huge duh, but I'm serious. If there's any way to increase your benevolence funds in your church, do so. Maybe some other parts of your ministry are not being used right now because we're all in our homes and separated. So maybe you can redirect some of those funds. People need financial help. So the very first thing I would say is to increase your benevolence funds. If you can, there may be some people in your church who can afford to give more. Encourage them to do so because this is a time to share financially with our brothers and sisters. The second is coming up, the third weekend in May is the Action Alliance for Suicide Prevention is sponsoring their weekend of faith, hope, and life, which is a time to talk about in your messages, in your sermons about suicide prevention, to actually say that hard word, suicide, say it out loud. That weekend is coming up. You can go to their website, get information about how your church can be a part of it. It's simple, it's downloadable resources, and you can make a difference for people who are living on that edge of suicidal thoughts, maybe feeling like they can't go on. Then I would say is to offer, we have at Saddleback, it's been monthly, now it's weekly, what we call the Hope for Mental Health Community. It's online, it's on Facebook Live, or you can access it on my website. where we bring in nationally known experts about mental illness, about substance abuse disorder, social workers, helping from NAMI, people who are to help family members, to help those living with mental illness, to learn accurate information about psychoeducation, to build community, to have opportunity to feel not alone, to feel like other people are with you. You can tune into that, or you could sponsor a watch party. You can tune into ours just as an individual, or you can gather other people in your neighborhood or in your faith community and do a watch party and watch this. We're doing them now weekly. We just did one on Sunday with Dr. Bruce Perry on the effects of trauma and stress in our lives, and thousands of people were comforted by that. Then the next thing that is a practical thing that you can do is there are online support groups, and I've listed Fresh Hope, Grace Alliance, the Depression and Bipolar Support Alliance organization, Grief Share. All of these are meeting right now online, and if you don't have a support group in your church for people living with mental illness, here are some very trusted support groups that you can encourage people to be a part of to increase the amount of support, talking too fast, to increase the amount of support and care and connection that they're getting on a weekly basis. Another one is called Journey Toward Hope that we offer at Saddleback, and you can download those materials and offer those, again, online for people to get care and support. And then the next thing that I would suggest is Celebrate Recovery is an incredible program that has been around for 30 years, helping people work with their hurts, their habits, their hurts, habits, hang-ups, and they've always met in person, but due to the COVID-19 crisis, they're now meeting online. And so you can go to celebraterecovery.com, find a group in your area and join online and get that support, because as we've already talked about, it's really difficult to maintain sobriety. It's difficult to maintain those good habits that you're trying to put into place in this time of stress. So these Celebrate Recovery online groups will be an incredible way to support you in sobriety and taking steps toward mental and emotional and physical health. And then another resource is online counseling. As Dr. Murphy mentioned, he has a practice that's mostly telemedicine. I'm sure Dr. Gersovich is as well. There's betterhelp.com is affordable counseling, much more affordable even than out-of-pocket rates many times. And you can go to Better there and work with them to find an online counselor. Another one is Faithful Counseling, which is an exclusively Christian-based counseling, but you can connect your parishioners to this online counseling service. In January of 2021, Saddleback will be offering what we call our lay counseling training online. That's where we have trained just average people. They're not mental health professionals. They don't have mental health training, but they are able to take 90 hours of training, and then they do some low-level free counseling for people in our community. That's going to be online for your community, for your congregation to be able to take that training in just a few more months. Then the next thing that you could do right now is you could encourage small groups to study online, and at pastors.com just happens to be one of many sources where you could go to get some small group Bible studies, so that the people in your congregation can continue to meet, can continue to study God's word, can continue to pray together, to worship together, to feel that connection. That connection is probably the deepest hurt than any of us are feeling. And when your small groups can continue to meet, and there's some material where they can go and find to be able to keep studying. And then the next is one of the things that every church can do, regardless of your size. You don't have to be a big church. You can be a tiny little church, is to do what I would just call a care caller. It's a name we made up, but it's just go through the database of your congregation, have some volunteers who will just go through and make a call to people who, and just say, how are you? How are you doing? Do you have some needs that our church can try to meet? It's a way of a voice, hearing that voice in your ear. You could do it by text, but I think voice to voice at this time is so important, but that's within the reach of every congregation. And then I was thinking that You might want to, one of the needs that people have right now is around food security, or not having enough food, or not being able to access what they need. And we've started, we have a food pantry, several of them at Saddleback already, but we've done what we're calling pop-up food, so that we go to locations and bring the food in a pop-up way, and or drive through. People can actually drive through and get their groceries. So if you'd like to know how to do that, there are the directions. You can go to that website and figure out how maybe your church could be a part of a drive-through food bank. Maybe you've never done it before, but this is step by step by step, how you can be a part of making sure that people in your community get the food that they need. And then I would just say in closing that, as we've already talked about, we have to prepare for a tsunami of grief and trauma that's coming. There truly is going to be an enormous need for people to be able to process their losses, to process their grief. If you've never started support groups, if you've never started Grief Share, this is the time to be thinking of how do we prepare our congregation to manage, to comfort, to help people process the incredible losses, the incredible traumas that they are experiencing at this time. I just saw today that there's a new task force called the National Mental Health Response. You can go there and look if you want to be on their website, just to stay in touch with, this is people recognizing that this tsunami of grief and loss is coming, and they're trying to get ahead of the curve, and you can stay with their information. And then I'll close with this verse. I talked about time and how this is our time. Ecclesiastes 3:1 says, "To everything there is a season and a time for every purpose under the heaven." As I said, we didn't ask for this time. We didn't ask to be part of the COVID-19 generation, but that's the time that's been given to us. This is a time under heaven for us to step up, to stand by people, particularly those on the margins, those disenfranchised, those living with mental illness. This is a time when the church, when the faith community can shine with the love of God.
Thank you so much, Kay. That was so thoughtful and insightful. I really appreciate the very practical recommendations you've made to the faith community of all stripes around our nation, and we're so grateful for your participation with us. We want to see Dr. Murphy join back with us in video, and we have time for about 5 minutes worth of questions, and we do have some questions that have come in on the Q&A chat box in the bottom. So let me ask this one. I think this is one that everyone is dealing with, faith community and not faith community, is just the reality of social isolation. So to reduce social isolation, many faith leaders are connecting with people in any way possible. They're doing online. You mentioned a number of them, Kay, online, phone calls. So is there anything in the research that suggests there is a best way for us to connect with people? Or should we just connect with them in whatever way works for us as faith leaders? And that's open for everyone.
Well, Shannon, why don't I jump in and take this? That when you look at the research, there's clear benefit to what's referred to as befriending. And a lot of this research has to do with mental health issues among senior citizens. And that befriending, again, given the fact that it was done in a different context than what we're dealing with now, would often be like person-to-person visits, phone calls. I know that one of the things that the church that I belong to has done was that they were purposeful in terms of calling every person in the church over the age of 70. And they've had kids from the youth groups writing them letters to stay in touch with them in that way. I'll tell you that from my experience doing telepsychiatry now exclusively for the last 5 weeks, if it's possible to do something where you can see people while you talk to them, I think that's a lot more impactful. We have the opportunity beginning Friday to reopen our offices, but people have to wear masks. I can't work that way as a psychiatrist because, it's picking up on people, facial expression, body language becomes very critical in terms of knowing how to lend support. So I would think that anything, whatever you do in terms of helping people to feel connected will be a benefit. the extent to which you can get people involved in activities where they can at least see other people while they're talking to them would be something that I would definitely encourage churches and other places of worship to do.
Terrific. Okay, Dr. Murphy?
Well, let me add something to that if I could. Two dimensions I want to offer here: solitude versus isolation, and community versus alienation. The church is built on a community, and people have lost that now. Alienation is this outside force where sometimes we will look down at people who have fallen, who've done things wrong, and the value of community, of reconnecting, is huge, coming from the churches towards the individual. But the other lesson to teach people is to appreciate solitude and not just isolation. When we've been through trauma, when we've made mistakes, goodness knows I've made my own, we want to isolate and be away from things. Nothing could be more unhealthy. But to learn to walk in solitude and appreciation, in prayer and meditation, and live comfortably in your own skin is a great lesson to teach. Not just say people, yeah, attaboy, attagirl, you can make it, but to let them know there's a lot of great things they could be doing in their own minds at this time too, therapeutically.
That's good. Okay, any further thoughts on that?
I'm so sorry. My son called me on the house line. I'm like, stop.
We'll go to question 2 then, because you covered so many good ideas in your presentation.
My son wants to connect with me. Speaking of connecting.
He does. That's so important. I completely agree. So let's go to question number 2. What about faith leaders who are skeptical about mental health issues? I think we have everyone on this webinar today has dealt with those in the faith community who are skeptical. And so seeking how to encourage those faith leaders to engage, particularly in this moment where we're seeing an overwhelming response from people who have no mental health diagnosis at all. The stress that Steve talked about in his presentation that our physicians and medical community are experiencing. We have just a few minutes left, but I'd love to get just a brief answer from each of you if you have thoughts on that.
Yeah.
I kick in from a clinical standpoint first, the idea being that the treatment of mental illness is not one or the other, it is both and. Faith is an important part of healing and connecting. But severe mental illness, we have to understand that is a brain disease. We don't look upon Alzheimer's or dementia or traumatic brain injury as somehow related to a bad life. It is something that's the clear deterioration of the brain. It kicks in about half the cases by age 14, about 75% by age 24. It's so important to work there. And that's where faith leaders need to work with psychiatrists, psychologists, that people can work with that. But never, ever, ever look upon someone as, and never say things like, you're doing this because you're being punished, or you didn't pray enough. There are clinical things to do, but do both. Okay.
Mm-hmm.
I was just going to say, I think it's incredibly important for faith leaders to be authentic, to be real. I started this by saying, I get scared. I wish my life was the way it was. And I don't feel like that diminishes I think that if anything, that endears us as faith leaders to those that we're with. If other people, those living with mental illness, those who are finding that faith is hard for them in this moment, if they hear us say, yes, I struggle too. It's hard for me, but I believe in a good God. I do not understand. I don't think we have to give people shallow and trite and just goofy answers. I think we can just be real, that God can be trusted. There's a lot about him I don't understand. There's a lot I would change if I could, but I'm absolutely convinced that he's good, that he loves every person that he has made. And the more that I show by my actions and my kind and my compassionate care for them in their suffering, in their struggle, my coming alongside, it makes God more attractive than less attractive. And that's what I want. I want to connect people back to a God who cares for them.
That's good. Dr. Gerspich?
Okay, so 2 quick ones from my perspective is that, one, when prominent faith leaders step up and talk about it, I think that does more good than anything else. And I think that Kay's husband has probably had more impact in this arena than any other faith leader in America because of his willingness to be able to do that. Chuck Swindoll had a wonderful blog post the other day talking about depression, and talking about how that's not something that is related to a problem with faith. The one other thing I would suggest the faith leaders might do is that different denominations, larger organizations, have platforms available to communicate out to other faith leaders around these issues. I'm honored to write regularly for the ERLC of the Southern Baptist Convention, and they've done a wonderful job of destigmatizing mental health. If this is something that you're passionate about, I would, they're constantly looking for people to develop resources for those types of platforms. Speak into the issue, talk about it, on your own blog, talk about it on your own social media platforms, and talk about it when you're doing online worship services, because what families wanted more than anything else was for their pastors to talk about it on Sunday morning.
No, I think that's so good. I think just acknowledging it out loud as a faith leader from your pulpit is so significant, because it says it's safe for you to come to me. It's safe for you to come and share what's on your heart and what you're struggling with, because we love you here and this is a safe place. So we could go on, I know, talking about these things. It's been so delightful to be with each of you and to see your faces. This is important. I would much rather sit at a table with you, but at least I get to see your faces, and I'm grateful for that. I want to thank all those who've joined us on this webinar today. We have just started this discussion, and it will be ongoing. As I mentioned, this is a first in a series of 3, if not 4, webinars. Our next one will be on May 12th, also at noon, and that one will be on dealing with trauma. And I think, unfortunately, we're going to see significant trauma coming out of this COVID experience that we are having as a nation and as a world. Let me just remind everybody that we will be sending out the link to the video. After this, you'll get an email in the next day or 2. We will provide the resources that were mentioned by our 3 distinguished speakers in that email follow-up to you. And so look forward to continuing to be in touch with you. If you want to sign on to our newsletter so that you can get ongoing resources, please do email us at partnerships@hhs.gov. And one last note is that because of all the work that we've been doing for the last few years, we do have a mental health and faith community guide that will be coming out within the next week or 2. We're really excited to share that with you. And so we will be sharing that in the coming days. Thank you so much for joining us today, and this will conclude our webinar.